I'm ready anytime, Mark.
Great. Thanks everyone for joining us today. And I'm here in lieu of Roberta Keller, who is on service this week, consult service. So she asked me to go ahead and begin with an introduction for Priya Parikh, who's a chief fellow in our HEMONC fellowship training program at UCSF. And just by way of introduction, I have learned that Priya graduated magna cum laude from WashU in St. Louis, and then stayed in St. Louis for medical school at St. Louis University, where she earned a distinction in medical education with a certificate in university teaching skills. From there, she went on to UCLA for pediatric residency training, where she was active in research, worked on a project reviewing acquired prolonged QT syndrome in children undergoing bone marrow transplant. She did that work with Dr. Ted Moore. And then, as I think I mentioned, she's the chief fellow in the HEMONC training program. Both Alejandra Sweet Cordero and I have been impressed with her work, with Marcia Treadwell, focusing on social determinants of outcome in sickle cell disease. And she's also pursuing a master's degree in clinical and epidemiological research at UCSF. So it's a great pleasure. We hope to entice Priya to stay with us a bit longer at UCSF, and this is the talk that I've asked her to give for the faculty. All yours.
Thank you so much, Mark, and for everybody for having me today. That was a fantastic introduction. Cannot have done it better myself. Gives you a little sense of who I am and my research interests. Today, I'm incredibly thrilled to present a little research update on what I've been working on over the last year or so. So that being said, let me go ahead and share my screen. And Eve, please let me know if something looks off here compared to how it looked before. But I see my slides. Hopefully everybody can. So the title of my talk today is Living with Sickle Cell Disease in the Context of COVID-19. And I have a couple main objectives here. First, I'd like to provide an overview of COVID-19 and what I like to call the syndemic framework. Second, I'd like to discuss sickle cell disease-related outcomes in the setting of the pandemic. After that, I'd like to discuss my ongoing research to understand the impact of COVID-19 on sickle cell disease through my work with the SCDIC. And lastly, I'll touch on my future next steps and research interests as it relates to the topic that we're discussing today. So let's talk about COVID-19. We all know it's unfortunately had such a devastating impact on everybody, all of us, right? I think really important to recognize is that COVID-19 has been quite a highlighter and quite a spotlight on health inequities in the US. We know, and it's been well demonstrated, that people who are Black or Latinx really do show higher rates of infection, hospitalization, death, lower rates of vaccination and vaccination uptake. We know that disparities have not only been present in a physical health realm, but also in mental health and resiliency measures. One study that I actually find quite striking is that early on in the pandemic, nearly 30% of Asian American young adults, 20% of Black Americans, and 15% of Latinx patients really felt like they felt discrimination and discriminated against during the times of the pandemic, which took quite a toll on things like anxiety, depression, coronavirus victimization distress. So we know that this has been well documented in minority populations. I think it's really important to consider that at the intersection of race and health inequities are really those with sickle cell disease and our patients with sickle cell disease. We know kind of by virtue of the disease, a lot of these patients identify as racial and ethnic minorities. And it's been well demonstrated that they have a higher exposure to negative social determinants of health. So to talk a little bit on what has been the demonstrated impact of COVID-19 on those with sickle cell disease, I will say up till now, some of this early research, understandably so, has really focused on clinical implications. So how many patients were diagnosed? What were their treatment courses? What were their outcomes? And how was healthcare being utilized? A lot of this early work has been done in institution settings through case reports, through administrative data. There's one really excellent registry that I like to look at in terms of clinical outcomes that has worked with several different institutions in the US. And that's the registry you see here noted, which is called Secure SCD. They have done quite a nice job of showing different clinical outcomes as it relates to sickle cell disease. By virtue of the work that's really been done in terms of clinical impact, a lot of this is relying on, again, case reports, institutional experience, systematic reviews. So what's really lacking here, and this is sort of why I mentioned this, is the patient voice and the patient-reported experience. This is a nice graphic that I like to highlight from the Secure SCD. You'll see the different sizes of the circles as representing different incidents sort of throughout the US and several of these institutions that are participating in this very specific clinical outcome registry. Next, and I think this is a really important slide for me, is to talk a little bit about COVID-19 in the setting of a more sociopolitical context. So in 2020, if you think back, we really saw the emergence of several different things happening at the same time. One was COVID-19, of course, and the other is we really saw this pandemic or a twin pandemic of systemic racism and implicit bias. If you can recall, the murder of George Floyd happened in this year and really focused a spotlight on racialized violence that's been a part of our country for a very, very long time, really since the forced migration of Africans. So we saw sort of the light of that, the systemic racism, the implicit biases that had already been on the rise, and unfortunately, no less in healthcare than in other settings sort of in our climate. And in addition to that, we saw COVID-19 arise, and we saw these sort of two twin pandemics then colliding. And because of that, I really like to think about the syndemic framework. I think that this really takes into account what is going on in this very unique time period that we've been living in terms of COVID. So the term syndemic was actually coined by Dr. Horton back in 2020, shortly after the emergence of the pandemic. Was published in Lancet in 2020, and really says that not only do diseases happen in a biological way, but that we should be taking into account sociological context of disease. So by virtue of the rise of inherent sort of systemic racism and explicit systemic racism, in addition to the rise and sort of acknowledgement of implicit bias that affects provider relations with patients, interpersonal communications, we know that clinical outcomes are affected. In addition to this really novel coronavirus epidemic that had happened, which then highlighted the need for further scientific development, we sort of saw this perfect storm and collision of these twin pandemics. So I really think syndemic is a nice way to take that into account. So that being said, a couple background slides there on COVID-19, what has been done so far in the sickle cell space. And now I'm really, really thrilled to sort of present some updates on my research project on behalf of myself and my co-collaborators that you'll see listed here. The title of our project is Evaluation of the Impact of COVID-19 on Individuals with Sickle Cell Disease in the US Using Patient-Reported Outcomes. And you'll see here a list of my co-collaborators. To talk a little bit through aims and research questions. So our study is really aiming to fill the gap of patient-reported experiences and outcomes to really represent the patient voice during this time, which just hasn't unfortunately been represented up till now in terms of COVID-19. The two kind of main research questions that we have are, how is patient-reported pain experience, psychosocial well-being, and general health affected in adolescents and young adults with sickle cell disease through the pandemic? And secondarily, what is the clinical presentation of COVID-19 in a COVID-positive patient cohort in our adolescent and young adults with sickle cell disease? We had an a priori hypothesis, and sort of as mentioned in a couple of my previous slides, coming from what has been known in the literature in terms of racial and ethnic minority populations, and a little bit also in our previous experience with sickle cell disease. But essentially, we hypothesized that adolescents and adults with sickle cell disease will experience a more negative psychosocial impact during the pandemic in specific outcomes of emotional distress, social functioning, and overall health. I'd like to spend just a couple moments talking a little bit about the Sickle Cell Disease Implementation Consortium, also shortly known as the SCDIC. This was a really nice slide put together by one of my co-collaborators, Dr. Robert Gibson out of Augusta. This is a very unique consortium that we have here. It's really the first of its kind to focus on implementation efforts in the setting of sickle cell disease. So the main sort of development goal was to develop a registry of individuals. There's about 2,400 and maybe even a little bit more at this point, represented through 8 different treatment centers. They're all adolescent young adult patients. The age group is really 15 to 45. And they're being followed at baseline and annually in terms of patient-reported surveys. So they fill out surveys every single year, as well as medical record extraction that occurs. Really, the main goal of the SCDIC was to conduct a needs-based assessment of the barriers to care for those with sickle cell disease, and to take that a step further. So not just understanding what those barriers were, but how to design implementation research studies that work to address these barriers. You'll see here, and hopefully it's not too small, but you'll see here a list of the different institutions, including sort of where they're located. Us in terms of our UCSF Benioff Children's Hospital, Oakland is represented, as well as a couple sites here that you'll see in the Midwest and the East Coast. I'm really thrilled to be working with actually all of the 8 sites, in addition to RTI and the NHLBI on this specific COVID-19 related project. To highlight here some of the key points of our methods, just in bullet point form, just so we can understand more clearly. The data source, as mentioned now, is through the SCDIC. By virtue of the way the SCDIC is set up, we have access to some of those surveys that are ongoing, and I'll speak to this a little bit further in more detail. But what was really unique that went hand in hand with this project was the development of a novel coronavirus and COVID-19 patient impact survey. The first round of this survey was implemented very shortly after the occurrence of the pandemic, so September 2020, and went up to June 2021 in terms of this first phase and the survey data, in which I'll be referencing today. As mentioned, in terms of the study population, it's really an adolescent and young adult population in the SCDIC. Therefore, they are ages 15 to 45. We have made the very kind of specific and conscious decision to include those who had completed a COVID-19 survey, so this novel coronavirus and COVID-19 patient impact survey, as well as those who had also completed follow-up surveys through the SCDIC within a month. And I'll speak to this again a little bit more later, but that was a very intentional decision to really understand what our patients were going through this pandemic, whether or not they ultimately contracted COVID-19 or not. Our study design is retrospective, it's descriptive, it's survey-based, again, using patient-reported clinical outcomes and measures. And I'll just point out here, even though we do medical record abstraction work through the SCDIC, that's not being represented, again, intentionally to represent the patient voice in this study. In terms of surveys utilized, there's kind of 3 that I'll be referring to for the remainder of this talk. So one is that new novel coronavirus and COVID-19 patient impact survey. The second is the patient follow-up survey that's routinely done annually through the SCDIC. And the third is a survey of my own creation that was done to understand more inward our institutional climates during the COVID-19 pandemic for each site. I've included here a brief overview of different measures that were taken from each of the different surveys. I will be going into a little bit more detail on this, but I just wanted to highlight some of these different kind of big categories of things. So for the patient impact survey, specifically in that novel coronavirus survey, we had questions regarding clinical measures, healthcare access, and psychosocial impact. In terms of the annual follow-up survey, there are variables and outcomes that we took out of those that really fall under patient-reported outcomes. So you'll see several of those listed here. Some of the big ones are Ask Me, PROMIS, which are all sort of validated health measure tools in the patient-reported outcome space. PROMIS is patient-reported outcome measurement information system. It's a well-documented patient measurement tool. Ask Me is Adult Sickle Cell Quality of Life Measurement Information System, which my mentor, Dr. Treadwell, was really instrumental in coming up with this validated measure. So I point these out. We'll talk again a little bit about them, but just for some familiarity about what we were using from each of the surveys. This is just a graphic just to give you a sense of what they looked like for our patients. It's sort of the top cover page, but through the SCDIC, you'll see here on the left, the novel coronavirus and COVID-19 patient impact survey, and on the right, the patient follow-up survey. So again, to get a little bit more granular into this patient impact survey, we asked several different questions. It ended up being about 20 different questions, all in these major buckets of things. So clinical, did you have exposure to COVID-19? Did you test positive? If you did you go to the ER? Did you need a hospitalization? What kind of treatments do you recall that you had? What kind of symptoms did you have? In terms of healthcare access and utilization, we had questions on, were you able to see your hematologist? Were you able to get a hold of their office? Did you go in person? Were your visits converted to telehealth or video visit? Formats that we're all familiar with did sort of emerge more so in the pandemic. And then sort of the big question mark for us was, how did this affect your life on a psychosocial level? Of course, on a clinical level, but what were your behaviors like? What were your stress levels like? Were you sleeping through the night? Did you have financial stress? How were your relationships with family, friends, loved ones really impacted by the COVID-19 pandemic? So in addition to that, we really did use these patient-reported outcomes and decided to use both concurrently, again, for that goal of understanding not just COVID, if you had COVID, what happened to you, but what was the climate kind of doing during that time? What were our patients going through more generally speaking? So we used several variables through these Ask Me and PROMIS measures, and two others that I'll review again, but brief resilience scale and experience of discrimination. And this sort of, again, goes a little bit back towards this known trend of implicit biases, systemic racism, how that's impacting people, how people were feeling discriminated against, especially highlighted by the COVID-19 pandemic. And then our four major outcomes, to distill down, two of which were related to PROMIS, so patient-reported outcome measurement information system, emotional distress categories, specifically in regards to anxiety and depression. PROMIS as a global health measure, in general, how good or bad was your health? And the Ask Me social functioning, which kind of gets to the psychosocial impacts of, what was your life kind of like? What were your relationships doing? What kind of stressors did you have that were not just about your specific clinical health? I mentioned a third survey, and this is just an internal survey, but just to get a sense of the kinds of questions we were asking about was to each different institution. As mentioned, there were 8 institutions that are participating in this survey. We kind of had this idea, and it's something that I came up with because, as we all know, COVID hasn't been a linear process. We know that vaccination rollout varied a lot by institution, by where geographically we're located in the US. So this was some of those questions that we were trying to understand internally speaking. When were your patients getting vaccinated? When were the majority being vaccinated? Where were vaccines occurring? Did patients and did people have an easy time getting them? Did they have a hard time getting them? So this was just a more internal institutional climate survey, just to understand for ourselves how these things were shifting through time based on each of our different sites. I have now a couple of slides just to give a sense of these patient-reported outcomes for those that are not familiar. What kinds of questions go along with which kinds of variables and outcomes? So in terms of asking about pain, in terms of this Ask Me measurement information system, these are the kinds of questions that are represented. So how many sickle cell pain attacks did you have? When was your last one? How severe was it? How much did it interfere with your life? How long did it last? So a lot of questions that kind of go clinically, what we ask our patients, but fall under this Ask Me pain episodes variable. We did also ask about disease-modifying therapies, specifically hydroxyurea, with a couple questions that we did pull out in terms of if you were taking hydroxyurea currently, or if in the past you have been taking hydroxyurea. In terms of a PROMIS measure, emotional support, we had different Likert and checkbox scales for a lot of these different questions, but responses to statements regarding how well supported you felt in your social life, how well you felt supported in terms of your emotional regulation, depression, anxiety, fear, NeuroQOLs, neuro quality of life. So things like lack of attention, slow thinking, focus, as well as difficulty with just ADLs or activities of daily living, like following instructions, time management, making appointments on your own. This brief resilience scale, sort of as promised, is a question that essentially states the following: please respond to each statement by marking one of those boxes in terms of questions regarding bouncing back, stress levels, setbacks, and how resilient as a self-measure patients or people feel that they are. And then this PROMIS Global 10 really just goes to overall physical health. So I didn't include each of those statements, but again, another Likert scale. We were interested in looking at barriers. So in terms of barriers, when did you not get the medical care that you needed? When did you have delays? How hard is it for you to pay for basic things? Did you lose your health insurance? And a lot of this kind of going to financial distress that was really happening in COVID-19. And unfortunately, we're still seeing some of those consequences. And then really important to us, again, in the setting of really kind of overt political context, is have you experienced discrimination? Has it prevented you from doing something? Have you felt inferior just by virtue of your race, ethnicity, color of your skin? So for us, this is really important to take into account as well when thinking about this kind of study, and really kind of wondering whether or not discrimination leads to worse outcomes. In terms of the data analysis plan, again, some bullet points here. A lot of this was a descriptive analysis, especially in our COVID positive patient cohort. We really wanted to know how many of our patients that filled out these surveys got COVID, what were their symptoms, what kinds of complications did they have, what kinds of treatments did they have, and using things like proportions, frequencies, very descriptive type analysis. We were wondering, in regards to some of these specific questions that I highlighted, what kind of visits were people having during the COVID-19 pandemic, and especially in these early days, and psychosocial impact. I'll say it again, was sort of the gap that we were trying to get at. In terms of patient-reported outcomes too, I mentioned several of those. Other things in terms of pain, hydroxyurea, social mental health, physical health, and barriers and discrimination. So all of those different things we were understanding in terms of descriptive analysis. This is a summary in table form. A lot of this you've seen before, but in terms of the independent variables, socio-demographic variables, and outcomes. The outcomes, as I mentioned, is 4 different ones in terms of patient-reported outcomes, 3 of which are related to the PROMIS system, 1 related to the ASME, and getting at anxiety, depression, overall physical health, and pain impact. The other independent variables are those questions that I sort of highlighted in terms of pain frequency, disease-modifying therapies, BRS, or brief resilience scale, EOD, or discrimination, access, and then we decided to use COVID positive and negative as a separate variable to kind of understand in our models whether or not having COVID made you sort of have a different experience than living through COVID. And then some standard socio-demographic variables, including age, gender, income, hardship, and health insurance. These are some brief results. That's just a general kind of snapshot of things and some general descriptives. So in total, we ended up including 653 patients. And again, those are patients that had been enrolled in the SCDIC that had filled out both this novel coronavirus survey as well as a nearby follow-up survey. So it had to have been within a month. As we can see here, just some initial kind of cumulatives and totals by site, by institution. We actually had a really decent amount, I thought, represented from each of our different 8 sites, which is nice. In terms of demographics, you'll just see below here, we had a pretty nice representation of age, everywhere between 15 to 45. In terms of race included, the majority was African American, and the majority was non-Hispanic, non-Latino, and we had a little bit more female representation, but overall just some general demographics here. The couple other descriptive results that I can share today is in terms of healthcare visits, we were sort of wondering again, what did that look like for people? I was actually pleasantly surprised to know that I think the majority of the people really were able to keep their in-person appointments with their hematology team. We did, of course, see the emergence of video and phone visits, which are the blue and orange columns respectively, which did see a rise. In terms of how COVID-19 pandemic has changed things for you, I don't know if it's too small to see on the screen, but a lot of this is sort of related to relationships, your income, finances, mood, sleep. For the most part, I would say most people felt like either things were the same or worse. So sort of as anticipated, we didn't see a lot of those things getting better in the pandemic. We saw a lot of either stability or worsening of those behaviors and stress levels and psychosocial impact. This ended up being our COVID-19 positive cohort. Again, just a very brief sort of table to highlight that. We had about 52 out of the 653 who self-identified as having had COVID positivity during this time period, with some, again, descriptives and demographics here on the right, and the symptoms in terms of percentages of those symptoms happening in those patients on the left. I think early on, a lot of this kind of related to some of those typical COVID-19 symptoms like fever and chills and shortness of breath and loss of smell and taste. You'll notice here about 40% of those patients also did identify as having pain crises in association to their COVID positive status. So again, just one of our aims to really understand for our patients, specifically in our E institutions, what happened when they got COVID. Then, and sort of now, the majority of what we're working on is really to understand our model. So first, we started off with the univariate analysis to understand the covariates that you see here listed on the right with our 4 specific different outcomes. Variables associated intentionally with a low p-value were ultimately included in our multivariate model. And again, you've seen all of these different variables before in previous slides, but this is the overall list of what we ended up including in our initial univariate model analysis here on the right. After that, we took the models and currently we're working through different multivariate analyses. All of them were adjusted for age and gender, sort of disregarding statistical significance. Again, just an a priori decision we made. Backward elimination was also used as sort of a way to reduce each model to really the significant predictor. So the outcomes that I'm planning to share today in subsequent slides are the 3 that are bolded. We're currently still working through the Ask Me Pain impact, but I do have some initial results to share for the PROMIS measures, so we can dive right into that. We saw for PROMIS emotional distress in the subcategory of depression using our multivariate models that we had a N, or a total of about 506 patient records to use. And what you see following that is just the internal scoring in terms of that specific measure of less than 60 and greater than 60. We found that statistically significant covariates, again, going through the process of backward elimination, included age 35 plus, which was actually a protective effect against depression. Financial hardship, especially in the somewhat hard category. You'll see a couple of the breakdowns in the model on the right, but we ultimately had categories of not hard, somewhat hard, and very hard. We had a loneliness measure as a sort of worser measure in terms of depression, whereas resilience was protective. So a couple of things I'll point out that I thought was interesting actually was a protective factor in terms of age, with older people identifying having less depressive symptoms and less impact in terms of the specific patient-reported measure in emotional distress depression. And then some of the financial hardships, I think, are kind of interesting to look at how people categorize whether or not they were somewhat impacted or worser impacted or had a harder impact in terms of financials. So we see that in relation to depression. So some of those kind of major factors with financial hardship, age, loneliness, and resilience as affecting this specific measure. Similarly, we see anxiety, again, with an N of about 506 and the 60 referring to the scoring of that specific measure. Through modeling of this PRO, we again found that age 35 plus was protective against anxiety. We found financial hardship to be correlated, but actually this time in the hard, very hard category, not somewhat hard. Loneliness was also impacting people's emotional distress in terms of this anxiety subcategory. Brief resilience scale, I don't think I had room to add that here, as well as COVID impacts. We saw that COVID itself was creating sort of worsened anxiety states of people. And then in terms of global health, which was sort of the overall general health category and not specifically related to a psychosocial or mental health impact, we had about 461 records that were available for this one. We saw that statistically significant covariates included age 35 plus, which, you know, understandably actually had a worser effect on global health. We saw that financial hardship again remains statistically significant in that somewhat hard category. And we found that when people had more pain and when they had a baseline, worse medical history or sort of more significant comorbidities, that this was also affecting global health. In addition to resilience, sort of as in previous models, we saw that this was a protective effect. So a little whirlwind on where I'm at with this research project. You know, we're currently working on finalizing some of these models, and I unfortunately don't have the pain impact to share with you today, but I am more than happy to discuss some of these granular details with anybody and hope to have my paper out this year. So in terms of, in general discussion, I think a lot of our hypothesis is remaining true. I think we are surprised by some of the findings, and I think there will end up being several different reasons for that, whether or not it's a data issue or just something that, you know, as researchers, we are not living the exact same life of those that are going through this. So I think it'll be really interesting to kind of see what our final models end up demonstrating, but there are a couple curveballs, I would say. I plan to really take all of this into account. Again, I think I can't highlight this enough, how much I think this needs to be taken in a specific context of this endemic, because a lot of these issues are really highlighting systemic racism and implicit biases that arose and kind of came to the forefront even more so during COVID. In terms of limitations, again, important to always mention these ones, but sample size, I actually think we have a very decent cohort compared to a lot of studies that had previously been done, especially given that this is a more novel approach in terms of understanding patient-reported outcome by actually using the patient-reported voice and through surveys. However, you know, we are running into some limitations in terms of all the variables that we are interested in looking at in sample size. We did have some missingness. I think in general, we had a very nice completion rates for our surveys and all the different outcomes we were interested in, but we do have some missingness that we're working with. I think the nature of patient-reported outcomes, for those of you who do this work, is different. It's different than sort of clinical data in terms of medical record abstractions or querying APEX, because it's really relying on people's report. And I did, you know, see and we saw that sometimes people had different kind of perceptions, and I wonder if some of that is the way we ask questions, or if things, you know, change really quickly between a month filling out follow-up survey and COVID-19 survey. So I would say that is a limitation, and by nature of this work, I think it's something that's inherent. Again, determination of PROs is sort of just like I was saying, some discrepancies that we found in a couple of the records and between the surveys. And then varying changes to COVID-19 climate, I think, you know, early on, and even when we sort of conceptualized this study, I don't think any of us really knew what the trajectory of COVID would be like. And so now we're on, I don't know how many variants in, but we saw, especially early on, so many different changes with different variants. And once vaccines came sort of to the scene, a lot of different early changes to that. So sort of was trying to get to that with some of this institutional climate survey that was done. But yeah, just mentioning that things might have looked different in different regions. Again, this study is really only focusing on the early pandemic time, 2020, 2021. Subsequently, we've had Delta and Omicron. So this is really going back towards that initial stage of COVID. I'd like to end by just pointing out this resource. This is through the Sickle Cell Disease Association of America. And for all of us who sort of see patients with sickle cell disease, this is a really, really nice resource that's provided. It has information on vaccines, how to keep generally healthy during the COVID-19 pandemic. It has a Facebook group for patients to sort of connect with each other, which I think is a really nice resource. To spend the last couple minutes talking a little bit about future directions, I'll share with you what I'm envisioning in terms of this specific project and give you a little bit more sense of who I am and where I hope to take my career in the next 5 years or so. So in terms of this COVID-19 project, again, we're really hoping to have things finalized early this year. I really hope to push it forward to publication this year in 2023. I think by virtue of having some of this data and the unique position within the SCDIC and my involvement with the SCDIC, one idea I have is to look at some of these PROs in the pre, peri, and post-pandemic time periods. Since we have some of the survey data, I think it'll be really interesting to follow some of this over time instead of just a one snapshot cross-sectional sort of view of things. I think similarly, seeing trends in impact survey over time will be really interesting to look at. So kind of in the back of my head, have an idea for either an ITS or a mixed models strategy to sort of over time understand some of these effects and patient impacts, especially in that psychosocial impact realm over time. Many of you know, another one of my big interests within the sickle cell disease realm, especially given my interest in pediatric hematology, is to really understand what the effect is and impact is on our Latinx patient population with SCD. It's a very understudied population, and this is sort of the next big project that I'm tackling in terms of understanding clinical and PROs, and specifically Latinx adolescents and adults with sickle cell disease. Ultimately, I'm very interested in moving towards a mixed methods model and career. I think specifically within the SCD community, especially as somebody who doesn't identify as a sickle cell warrior, is to incorporate the patient voice. I think by engaging in qualitative and quantitative work, in addition to community engaged research, we can have a more robust understanding of what our patients are going through and really understand, be able to describe disparities, inequities, and how we can do better in terms of systemic racism and implicit biases as providers. My overall career goal, I would say, that being said, is to really use implementation science to take established and known disparities into action to reduce inequity. So I've been really thrilled to participate in the implementation science track through my master's and look forward to continuing that kind of work. So to summarize, we spoke on a lot of different things today, but to summarize and sort of key takeaways from this specific talk is that COVID-19, we know, presented challenges for our patients with sickle cell disease, specifically in the context of a pandemic. We know that personally mediated and structural racism contribute to disparities. Ongoing work is occurring through this project that I'm leading through the SCDIC, and we hope to continue more work in this realm. Further, personal interest in work centers around understanding the patient experience, exploring inequities in care, and establishing interventions to reduce noted disparities. I'd like to acknowledge, finally, the Sickle Cell Disease Implementation Consortium, my collaborators who who allowed me to take ownership of this project. And as a fellow, really have pushed me in great ways and have been incredible collaborators. And my mentor, Dr. Marcia Treadwell, who has been absolutely fabulous. And I wouldn't have made all this progress without her. So it's been really instrumental in my career development. And of course, to all our patients and those affected by the COVID-19 pandemic, it's been an unprecedented time, as we all know. So my huge grateful thank you to our patients who we learn from every single day and get the privilege to take care of. So thank you so much for your attention. I think I did my talk within the 45 minutes as anticipated. So I'd have some time for questions. I'm happy to take any questions now or at any time. Please do feel free to email me. I'm more than happy to speak on this work, or if you have any ideas or clarifications, I'm absolutely more than happy to chat anytime. So I will pause there. I have some references. Again, if you're interested, please reach out anytime, but I'll stop there and spend the remaining time answering questions.
Thank you, Priya. That was terrific. Really enjoyed your talk. So I'll help field the questions. Somebody wants to begin.
I have a question, Priya. This is Neha.
Hi, Neha.
Hi, that was a great talk. Good job with all the work you did. I had a question about all these measures that you're doing, patient-reported outcomes. I'm sure this is not the first time patient-reported outcomes have done in different diseases. So I guess I wanted to hear from you what work has been done in patient-reported outcomes in other diseases that may affect a certain group of patients. And I would like to see how your data compares to that work.
Yeah, that's a great question, Neha. A lot of the patient-reported outcomes that we're using are previously validated measure tools. A lot of them actually come from the adult world, including things like PROMIS and ASME. ASME is the more, I would say, one that's more relevant to our field in terms of hematology. And that actually was done by Marcia back in 2014 and took some of these already validated health measure tools and have taken it and really specifically identified sickle cell measures that can go hand in hand with those. So I don't know if I'm understanding your question exactly right, but a lot of this is sort of adult measures that have been adapted and was initially in the SCDIC consortium utilized as a way to understand some of these psychosocial impacts, was built into sort of the creation of the SCDIC. And back in 2014 is when we had a little bit more available in terms of the measurement tool with ASME specifically.
Have they been used in different diseases at all?
They have, yeah. And I guess I'd have to refer to health measures. There's like a website and a whole body of literature on that. So I don't know off the top of my head, Neha, the other kind of adult diseases that this has been used in, but it certainly has.
Thanks.
Ask the next question.
Hi, Ash, of course.
I understand the patient side of it, the inequities that are in the system and so on, but it isn't just the access to care. It's also the fact that care simply doesn't exist in many places, and that to me is just as equally big a problem as the lack of adult expertise in managing a chronic disease that starts in childhood and had previously not been thought to be as big an issue for adults, but now in the last 2 decades, the survival has been extended so much that so that places, I think, the adults in a situation where they unless they're living close enough to a system that can provide comprehensive care, their outcomes are at risk, and all the benefits of comprehensive care during childhood could be lost very quickly.
Thank you for pointing that out, Ash. I completely agree with that. I know there's some ongoing work through the SCDIC, and Marcia is also involved in an unaffiliated patient project. And for my sort of interest also in Latinx patients, that is one of my goals too, is to really understand who even has access and who doesn't have access. We know a lot of our kids don't have access to nearby centers. While overall I was happy to see that in this adult population, a lot of people already plugged into care had more or less access to their hematology team. I think absolutely we're not capturing those who don't have access, and that remains a huge, huge inequity. So I know that SCDIC sort of has an overall aim, and I think it is something for all of us to consider how we continue to move that forward and how we get our patients established. But I agree completely in terms of that being a huge inequity and sort of contributing to disparities in care and sort of outcomes and healthcare delivery.
Amit just posted a question in chat, wondering if you could discuss some of the variants you observed in the institutional climate survey. Were there major disparities or differences in COVID protocols across centers that might have affected some patient experiences at certain centers, or was it fairly uniform at these tertiary care centers?
Yeah, you know, the biggest disparity or discrepancy that I actually saw in that institutional climate survey, I was pleasantly surprised to see that a lot of institutions were sort of offering vaccinations in a similar time frame. I think the two kind of biggest differences were, one, where institutions were providing vaccines. For example, you know, was it whether in the institution itself, like through the bigger UCSF, for example, was it provided right then and there in hematology clinics? That was the case at some institutions, whereas others actually, for various reasons, and it sounds like anecdotally, a lot of their patients actually just went to the nearest drugstore, even if they had comorbidities or underlying conditions. So I would say that was one big difference that seemed to be slightly different between all the different institutions. I think rollout happens at a similar time frame. And in terms of majority of patients that were being vaccinated, that was one question that I had in there as well. There was some variability in that as well by institution when asking the question of how many patients in terms of the majority, by what time frame were they getting vaccinated. So I think in general, it was a similar timeframe rollout, but where patients were getting their vaccines and by when they were getting their vaccines differed. Thank you for your question.
All right, Mel Hyman has his hand raised.
Hi, Priya. Thank you for that interesting study and report. I was curious if you looked at all at the impact of COVID on sickle cell crises, given the potential vascular involvement there, and how that might have impacted also, especially with disparities.
Yeah, I think I lost just a little bit of email, but that is one of the outcomes, but unfortunately I don't have that data to share today, but you're absolutely right. That's our question mark as well, is how that affected pain crises and pain episodes. I will say, based on the COVID positive patients, about 40% of those patients did report having a VOE during the time of their COVID positive experience. But that is one outcome that we are exploring. I just unfortunately don't have the data as we're finalizing that model to share today. But it will be interesting to know, and I think we have the same hypothesis.
Yeah, thank you.
Thank you.
Other questions? Okay, well,
we have a few minutes. I don't want to take
Ash,
time
before yours, Naomi
Yeah.
Bardock just put her hand up. So go ahead,
Okay.
Naomi.
Hi, sorry, thank you. This was great work, Priya. Thank you so much for presenting it. And I'm sorry if I missed this, but I was curious, when you said follow-on work, you were hoping to do an additional survey, were you thinking about doing that in kids? I was just curious. It seems like there's so much to be asked also about the kids, even at the younger ages.
Yeah, I'd love to expand and explore a little bit in kids, especially given that I'm on the pediatric side and pediatric hematology. It's a very good thought. I'd love to maybe explore actually with you later, Naomi, how that might look like through this consortium and surveys that have sort of been established. The data that we would have longitudinally is in adults just by virtue of who's eligible to participate in that. So that's why the 15 to 45. But I actually agree. I think there's a whole sort of pediatric portion to this, like, less than 15, for example, that's not being represented. And I think parent and caregiver attitudes would also be very, very interesting to explore in the setting of COVID-19 and sort of an already challenging situation for patients. Thank you for that.
It is interesting that during the same era that you're looking at with regard to vaso-occlusive painful episodes resulting in hospitalization, that overall VOE hospitalizations precipitously declined during the pandemic for a lot of different reasons. So it's interesting that 40% hospitalization rate, that's probably spectacularly high compared to the general population. Go ahead, Ash.
Yeah.
It's just one aspect of the pandemic was the decrease in blood transfusion donations that were, and the inability, I think we experienced that here with our local blood supplier, that they couldn't hold the community blood drives anymore. And so, and in that, I think the people that could potentially be most impacted with that is those who have complex antibodies and the risk of, is that something that might be just looked at? I think as for the hemolytic or the transfusion reaction, did more people than anticipated, or people who didn't previously have, what was the access to rare blood types during periods of the pandemic?
I think that would be a great thing to look at. We don't have that specific data, but I have also done a little bit of work thinking about the thalassemia disparities that have occurred in COVID, and just anecdotally, as you shared, I know I've asked you about this before, is sort of that reduced access to transfusions, and it was seen sort of worldwide on that kind of basis. There hasn't been much described, at least in terms of the search that I've done in sickle cell specifically, and unfortunately through the SCDIC, at least in this setup of this project, we don't have access to that data. But I think, and I would imagine as a whole, it's something we should all talk about, is whether or not we have that access to data to think about that aspect as well. Thanks, Ash.
It looks like there's a question in the chat. I don't know if you see it.
Yeah, I think we addressed that one, unless I'm missing it.
Okay, just wanted to make sure.
Thanks, Eve. Thanks for monitoring.
Okay, well, thanks everyone for a very stimulating question and answer period, and for Priya for such a interesting and informative talk. Really look forward to hearing more about your research in the future.
Thank you so much, Mark, and everybody for having me. And thank you for the questions and suggestions and recommendations. I'm really excited about this kind of work. So hope to continue that, and happy to connect anytime with any of you. So thank you so much for your attention and for joining today.
Thank you, Priya.
Thank you, Laura.
Bye, everyone.